So every one of you have seen this, have gone through this, but I think it's a good exercise to go back and review it at all points in time. So what we are saying is that the head or the occiput of an infant is big. So when I lie down, my neck is always going to be little flexed, like I'm going to go sniff a flower. It's going to be little flexed, right? And that's a problem because it causes a little bend. And the airway axis would not be in a plane that I would like to be this way, and this way. I need to make it straight so the laminar flow goes through. So I would like to make sure that I put a towel, not on my neck. It has to go under my shoulders, right? That's what we're trying to say there. Adult, not a big issue. Tongue, given the size of the infant, most of the tongue is intraoral, occupies a large space. And now if I'm going to lose my muscle tone, of course, it's going to go back. And the consequences leads to the next one because my larynx is so up ahead that the tongue is actually going to block that larynx going through, right? Look at it, C2. And all of you have it C5, C6, right? Because the vallicula is around C5 and we have to pull it up like that. And it is so high up there. And so if you say, open your mouth, ah, can you see my epiglottis? In a baby infant, the answer is of course, yes. You can see the epiglottis, right? So as soon as you have passed that base of the tongue, you're almost too far gone. That's why it's important to understand that if I'm going to lie flat and tube somebody, as soon as I pass that tongue base, you're done. You have to pull back because now you have to lift the epiglottis, right? Why? Because it is soft, it's omega shaped, and you will have, and it slips and lies on top of my vocal cord. So you can't see it, you just pass through my vocal cord, through my epiglottis. So you have to go back, lift the epiglottis so that now you can see my airway better, right? That's what we are talking about. Let me see, we can go back again. This is what I'm talking about. You see, it's omega shape, it is concave, and so you can see the difference how it already stands up like that. So the vocal cord, like I showed you, is short and concave and horizontal. Smallest diameter, it's very important to understand that. At your level, everything will stop at the vocal cords and not go through because that is the narrowest part. In children, it is the cricoid cartilage. So you are having a half a peanut. It's not going to stop at the vocal cord. It will go directly to the cricoid cartilage, a step below. I can't use the pediatric megals and take it out. I just cannot because I have to touch and go through the vocal cord, which I have to destroy now. So it's important to understand the narrowest point is the cricoid cartilage and not the vocal cord. The cartilage is very soft. If I take a deep inspiration breath at the negative pressure because of the softness, which collapses. And I'm not breathing anymore now because if I have to do that, right? And the lower airway is very small. And when I say that, look at this one, right? 4-8, I go up by add secretion, add edema, whatever you like. Look at the resistance 16 times. Look at the resistance in adults. So you have to have that concept of what it can do when you're going to have someone who has got very small airway diameter. Anything else I am missing here? Give me a couple more. Come on, the audience. Other differences that you can think of. Short neck, right? Have you ever seen an infant neck? It actually rests on the second rib. The chin actually rests on that. The hyoid bone actually overlaps my thyroid cartilage. If you really want to look at and do a percutaneous, you can't find the landmark. It's a major bummer. Unless you make it a habit of everyone you see to extend it, and then, if I ever have to go, I'll probably go here. We don't practice that, but just keep that in the back of your mind. Anything else? Give me a couple more. I'll give you one that I'm culprit of, and I can ask any one of you. A loose baby tooth. When I intubate, I broke one. Any takers on that? None of you? That's good. That's very good. You can crack an adult tooth, but a loose baby tooth will actually aspirate because you can't find it. It's such a loose one, right? What else? Short trachea. What is the concern with the short trachea? I move my neck and I can extubate myself, right? I move like this, I can extubate myself. So it's very important to think about those things when you're working the ED part of infant, right? Anyone, one more? Two more? Come on. OSA, right? It's always a problem. Big tonsils, big adenoids, occupying my nasopharynx, occupying my posterior pharynx. On top of it, the tongue falls back. There's no way to mechanically ventilate humanity, right? It becomes a problem. So recognition of all of these, I think, is very important to keep in the back of your mind. The next thing I want to understand with all of you is that how do I assess work of breathing? And that becomes the biggest challenge when any one of you work in the emergency room, right? You look at a child, and we always say the child walks in, and I walk with the patient. And because of what we practice, I know exactly what is wrong with the kid, right? But I think it is important to understand how to assess the work of breathing in an infant that you're going to see in the emergency room, right? And I always like to start with abnormal airway sound. Anybody will tell me anatomically where the upper airway ends and the lower airway starts? Help me with this. Where does the upper airway end and the lower airway start? So it is at the level of the glass, right? The level of the vocal cord. Anything above is upper airway, anything lower would be lower airway, right? So if I say acute laryngotracheobronchitis, it's an upper airway, but I'm using all these terminologies. It is because of the upper airway, the larynx causing stridor, is why it is called an upper airway obstruction. So be vigilant to hear these abnormal sounds that you can hear. Give me an abnormal sound you can hear, stridor. And they go very soft like this. And I've seen them in treated for wheezing all the time. So you have to understand and listen to these abnormal sounds all the time. Give me any other abnormal upper airway sound that you can hear. I'm going to stop. Come on, talk to me. Talk to me. Any other abnormal sound that you can hear that you walk through? How about gurgling? How about a muffled voice? How about hoarseness? How about a hot potato voice, right? All gives you inkling as to what you think may be wrong. And I think it's a good habit to do that, right? I walk with my wife on the mall all the time, and I keep pointing my to start looking at people. So I can't help myself. So when a child walks into the ED, you need to understand and listen to this first part of it, right? I think it's very important to understand. Anything with the lower airway, any abnormal sound that you can hear in the lower airway? Breathing, you can hear breathing, sure. Partial obstruction of the lower airway. Any other sound that you can hear? How about grunting? I would grunt. What am I trying to do? Give me a pathophysiology of that. What does grunting tell you? What is wrong with autopsy? I want somebody to expand on the word autopsy. How am I generating autopsy? What are you thinking? You're right, it is autopsy. So subconsciously, I'm partially closing my glottis to generate an autopsy so that it can open up my alveoli that is trying to collapse. Either I have blood, I have pus, I have something, right? I'm trying to open it. Sign of a lower airway, right? So you need to kind of think through that and be able to hear those sounds and say how sick I am, right? Because what I'm trying to teach is now the degree of intervention will depend how sick I am, right? I think it's also very good to know abnormal positioning, right? How am I holding myself? A tripod? I'm going to be dead next minute now. I'm opening all of my muscles that I can use. Now I can't use anymore, right? Any other positioning? Sniffing position, right? As we talked about. Want to make my plane go one way. Position of comfort. Leave the patient as it is. Whatever position he wants to be in. Don't bother me. Leave me alone. Just give me blow by, right? So understand the position that the child will take and make you understand that. Retractions, I think it is important to undress a baby. We do hear a lot, and many times I see my residents not undressing a child that I would like them to be. I always say less than 5 do a naked chest exam. I think it is key for us how we manage that. And it always should be mild to moderate or moderate to severe. And the lower it is mild to moderate. As I go up, I'm using more of my muscles. So it generally starts at subcostal, intercostal, supraesternal, supraclavicular, right? And then I'm going to do head bow. What am I doing now? I'm trying to contract again subconsciously, my scalene anterior and increasing my diameter this way. So head bobbing is not okay. Also, the nasal alveoli flaring is associated both with distress and with hypoxemia in pediatric medicine. So you need to keep an eye on that all the time when you're seeing a child. Please, as I said, ask me questions if something is not clear as I go along, okay? Now the question comes in is that once I have done this, as I told you in respiratory, I think it's important to be able to distinguish respiratory distress from a failure. How do I know clinically, as I'm walking by, I walk by and say, okay, I need to go here. Respiratory failure in pediatric ER, all hands on deck, right? Or what is I say, I can have my fourth year student look at it, maybe a resident will go, maybe a fellow will go, then I will go. I think it's important to understand that. So as soon as you see somebody with any respiratory illness in your head, make sure you understand it's going to be distress or a failure. And one way of looking at it is you have seen the work of distress I have. Now I want you to correlate that work of distress with how I appear. And with that, what I mean is that how am I ventilating, oxygenating, and perfusing my brain? Right? I think it's a very important concept, right? If I lose that ability with my distress, the diagnosis has to be respiratory failure clinical, right? Where you don't have any time. I need to intervene now. So that thought process is important. And the younger you are, it becomes difficult on how I know that you have an appearance that is going bad, right? And some of the ways to look at it would be to say, how alert are you, right? Again, alert meaning my basic state of arousal, how I look. Distractibility, a pediatric development and growth, when I was becoming a doctor, like it used to be 0 to 14 and 0 to 16, 0 to 18, 0 to 21. Now we are saying you're probably going to 0 to 25 now in our outside practice now, right? So the growth and development is just, we have to understand that the depth and breadth of it, right? Example of distractibility would be, I have a 2-year-old in the emergency room. What is his job description? His job description is to run from there to there, right? You take your pen light, shine, he's going to stop, look like this, and run like it, right? If you see an 8-year doing that, which we had, and hit his bicycle outside on the pole, and somebody brought him like this, and he was facing my ER like that, right? So you have to understand that, right? For me, Tejani, a 2-month-old coming in the ED at 2 a.m. in the morning with inconsolable crying, with altered mental status, and poor otherwise, it's not colic. Of course, it will be colic at the end of the day. It's like, but the answer to understand is that for you to think through this question is to say, inconsolable crying, all bets are. Think in that way. So as you go down to see the eye contact, anybody knows when does an infant start to see or have an eye contact? What age it develops? You examine the neonate all the time with me. 2 months, right? And then speech and cry, of course, I can speak in full sentences. I have a 4-week cry. We don't see high-pitched cry of meningitis anymore. I don't remember the last time I saw a case of meningitis. And of course, poor motor tone, poor activity lines, all of that. What I'm trying to say is that make that judgment call of how I appear, how I am ventilating my brain. And when you put distress with poor appearance, is what defines respiratory distress from failure. If my B is gone, it is distress. If my B and A is gone, clinically it is going to be respiratory failure. Okay. And again, the rationale is my intervention, right? Look at this one. You can read. So, failure, distress, what makes you say failure? What here it says it's failure? Excuse me?
Alternate.
And what says alternate mental status?
Pale, sleepy.
Sure, pale, sleepy. I don't need to know if you missed at 3 in the morning, right? We had this case of a head injury where a patient was sleeping at 5 in the morning. Like patient is sleeping, it's 5 in the morning, what is the 5-year-old supposed to do? But it's a head injury case and I can't let you sleep or whatever, I need to watch you more intently now. So timing should not help. In your head, you're trying to make an impression quickly. And the impression quickly would be that respiratory failure, all bets are off on this one. So my intervention, maybe it's not that I'm going to give you 3 treatments and I'm going to give you 2 epinephrine sec. No. You're getting your 2 epi. I'm going to put all of 3 with the 3 albuterol. I'm putting an IV. I'm giving you MAG. I'm giving you IV salbutamol. I'm preparing my terbutaline as we go along. It's all in the sense. Plus, I'm going on the mic and saying I need help. Right? You need sick people out there. That is what the impression I want to create in you when you say respiratory distress versus failure and how quickly you would intervene. Okay. Versus, run-of-the-mill stuff that we see, right? Student goes, the resident goes, the fellow goes, then the young goes, right? In that thought process, okay? And again, we talk about this because this is what would it be for a distress where I am doing nothing versus this is what I am doing when I'm automatically thinking respiratory failure, because I'm already thinking 3 steps ahead now what's going to happen, right? So the degree of intervention and then doing any intervention, stepping back and looking, did my intervention work? And then try again, right? That is very important when you are saying clinical respiratory failure. Yeah, good. I saw I don't know if anyone of you was with me. You saw a 1-month-old, I do not know, who presented with apnea. I think it was a Boolean. Is here? Oh, there you go. So we saw a patient like that, right? A bronchiolitis patient, apnea, classic bronchiolitis history came to us. And then next day, I saw a similar kid presenting with the mom rushing in the cage. My kid is not breathing. The kid looks right. But the history that he stopped breathing. And then we started to talk about. And another concept I want to bring up to you is a concept in pediatric we see called periodic breathing of the newborn. You need to go back and think you don't see enough, right? And so it happens in a second. I don't remember this. This is something I just knew. I knew now. Yeah, occurs in the second stage of sleep, and I'm not too concerned about that. But what it is that because of the immaturity up there, they go into a period of not breathing for 5, 7, 10, 11. And one study said 12 seconds of apnea, right? And so they breathe and then they stop and they start to come out. 60 minutes. And if you're one of those who takes only a 10 seconds and then multiplies by 6, you will cross 120 seconds on it, right? I'm breathing 120 times now. So, and then eyes will go back and forth, right? And so I think it is important to distinguish when we see something like this, when the parents give that observation, asking them the way I describe to you and demonstrate to you, that kind of thinking, and they'll say, oh yeah, that's what he's doing, right? But then how do we would differentiate it from that? So it would happen this way, yeah, made twitch or jerk, and eyes seem to move, and they will say the eyes were dancing inside the eyelids. Breathing is often irregular, may stop for 5 to 10 seconds, maybe more. And then start with a burst of rapid breathing so fast, you just go like 50, 60 times. And then, again, followed by a regular breathing cycle. And the key word is, I think, is that the skin color never changes. Unbelievable, right? 12 seconds of not breathing and skin color doesn't change. And then when does it stop? And I was trying to look at the literature for that. My idea was to stop at 4 months, but I went back and looked at it. And most of them said 6 months. But one study said 78% of them do this in first 2 weeks of life, and up 29% can do it almost up to the end of a year. I don't know about that. But the idea is that the first couple of months, 2, 3 months of life, if they present like this, when you're saying apnea, you're saying BRUE, breathe. I want you to consider this as a differential and ask questions and understand and see if you could fit into this periodic breathing of the newborn before we throw the book at that. Okay. The other thing I struggle with a lot, and Julian is a witness to it. Everybody nowadays in this winter month coming in, Tejani is giving them augmentin for sinusitis. And Julian is like, I'm crazy, everybody's sinusitis here. It's a very difficult diagnosis to make in pediatrics. People think it is so easy, you know, everybody walks in, has a green knot, and I'm like, this is sinusitis. It's going on for a week, it's going on for 10 days, it's going on for a month. Where do I draw the line? How do I diagnose someone? And I just wanted to bring you how I think. Tejani's bias on this. First of all, understand this, right? The new terminology that you will find is not sinusitis, it is rhinosinusitis, so it's the same mucosal lining. And so in the books, you will see viral rhinosinusitis. The same word doesn't change nothing at all. It is rhinitis. The key word to understand is that the sphenoid develops by 2 and does not hematize till 5. And your frontal does not develop between 7 and 9. So you cannot have a frontal sinusitis if you're a 5-year-old. So you tapping and checking for sinuses doesn't make any sense to be honest, right? But you need to understand that anatomy is so important to understand what I'm dealing with. Yes, they have ethmoid. Rudimentary is very, very rudimentary maxillary. But what they have is ethmoiditis. That is why they would get a periorbital or an orbital cellulitis extension to that. So, and what we're trying to talk about is we're not talking about people with comorbidity. When I use the word comorbidity, I am talking about immunocompromised people. The rule that I'm going to share with you does not apply. Cystic fibrosis, any mucociliary dysfunction, any of the syndromic things that, and of course Down syndrome, right? They have got a very abnormal faces. Their immunological development is a little different. So those are 3 or 4 categories I look at where I will not apply this formula. So then you have to think differently, right? So the American Academy of Pediatrics has 3 definitions for sinusitis. The first definition is anything URI, nasal drainage in cough for more than 10 days. Just a simple statement. If I have a running nose and a cough for more than 10 days, I have clinical bacterial sinusitis. Another story, right? The second definition they are saying is that I come with the first 3 days of my life of my having a runny nose. I have a fever of more than 102, and we'll talk about severe URI symptoms with purulent nasal drainage for more than 3 days constitutes bacterial sinusitis. And the third definition AAP gives you is that I have gotten better. Today is day number 7. Now I'm having the same second line that I have now again developed a fever of 102.3, 39 degrees or more, and I have a similar presentation. My diagnosis is bacterial sinusitis. They made it very easy for you to treat, no issues at all. Right, and so this we're talking about severe purulent anterior nasal discharge, posterior nasal discharge, facial congestion, sinus area, and then minor things on the end. What made this all a problem for me is that last year, this gentleman, he writes a lot about sinusitis and UTI. He said that we should do nasopharyngeal culture. So he said, do nasopharyngeal cultures on every sinusitis that you're concerned with. If the test is positive, then if you will treat them, study displayed a greater clinical effect of the antibiotic treatment than those without evidence of bacterial nasopharyngeal pathogen. So that was a statement. It became a huge thing, came out in JAMA. A lot of people wrote the editorials whether we should be following this or not. Huge thing. And again, with Tejani is like, now what am I going to do, right? So then the person who wrote the editorial said, the median duration of daily symptoms in this study who received antibiotic therapy was only reduced by 2 days. 7 days in the augmentin compared to 9 days in the placebo. It's 2 days different. Should I really prescribe them antibiotics? And the second comment was that when we get these organisms that we know of, right, where are we getting it from? They are our normal commensals. They stay with us, right? And when they go into a small, closed mucosal space, the local immunity should take care of it. When it does not, and they multiply, is where we say, oh my God, it went out of hand. I'm not importing it from anywhere else. And the 3 common we always talk about is strep pneumoniae, non-typeable Haemophilus, and Moxera. And now we know because of the vaccine, non-typeable has become number 1. Strep pneumoniae is number 2, and Moxera continues to stay 3, right? And so, but he said that, what if there are the normal commensals? How do you differentiate between the two? It could have been the normal commensals that you're trying to do, plus again, the cost associated with culture. I am not a primary care. I don't have the feature of time. I would love to do that. In my private practice, I don't have it. In my private practice, I would have time to call you back in 3 days, examine you again, see how you are doing. In the ED purpose, I don't know what we should be doing now because I have such simple definitions to look at. My adult colleagues here, how do you decide that in your adult population? You see a 20-year-old, what do you do? How do you decide? How do you teach your residents? Oh, this is the right way to treat the time. We all academics here. Anyone can say something.
Use a similar framework if it's something that's prolonged, because it's secondary like superinfection.
But how do you decide it? In UK, if you look at UK studies, you have to have sometimes some sort of a comorbidity. Their timeline is 28 days, not 10 days like us. Before they will give you antibiotics.
There's sort of a timeline where we see it. It used to be much more prolonged. Now they're saying 7 to 10 days. It might be more fun.
Oh, so
if you're
Okay. Hearing all of this, I have always kept it simple in the sense that I like the AAP definition because first of all, you need to take a test on that, so you need to remember their definitions when it comes on the board. And color is not an issue, right? Because anytime you do anything and you get a viremia, you get all of this. Kinase comes through, islet comes through that attracts the PMN, and the PMN comes in and makes everything purulent and green in color. Okay, color is not an issue at all. I think the persistence depends on whether you like a 10 days or a 14-day person, how chronic it is or not. I still follow the American Academy of Pediatric guidelines as I showed you, and I have no hesitancy of doing that. But just saying if you read something and this kind of a paper shows up and everybody wants to do an nasopharyngeal, it's out there. I don't practice it. I just wanted to make sure it's just there out there. Now, in PEDS also, they came out with something called as 5 wise things to do. Are you familiar with that 5 things that they told you in PEDS to do? We'll look at that one. And it's just a reputation, but every morning I come in, and just being who I am here at UHB, I go back and check how many viral cultures have, how many of these we have sent. And I'm just amazed, right? When I say comprehensive, I'm talking about those big panels of 20 viruses, and we are sending out tests is about $600–700. I'm saying we did this on this patient. Why did we do this? Why are we still doing it? Right? And I think this we need to go back and look at this one, right? That do not obtain comprehensive viral panel, right? Anybody would not agree with me? Anything in your mind that says not Tejani? If I have these X, Y, and Z conditions, I'm going to do it. Come on, help me. So, right? I sickle cell patient, fever 105, right? I'm checking Tejani chicken. I would definitely do it. Right? I'm just giving you an example of where I would put this and say, I need to do that, right? I'm going to hospitalize you and you need antibiotics, and it's going to change your stay in the hospital for 3 days. Will it make a huge change in time? Maybe I will do it. Some of us like to treat. In our hospital at USB, all inpatient, if you test positive for flu, do get antiviral, period. Right? And they demand that we need to do that because it changes the management. So if you're a kind of person who wants to treat flu, I will do it. And then, of course, if you're doing any kind of public health recommendations and surveillance, that's a different story altogether. Idea is that there is something called at UHB at least. I don't know about that PTS, you can guide me. You can only do 3. We do COVID, they do RSV, and they do flu. So if you want to do something and desperately want to do it, then use a less cost effective, cost-wise, which will give you the same results. But as a general principle, it's not going to change my management. You're going to, and remember, all of these comprehensive are nasopharyngeal. They are not nails. They are not anterior nails. They are supposed to be nasopharyngeal. I mean, you have to go into my nasopharynx to get it done. And kids become so uncomfortable. And everyone who has done it correctly, you have to understand if you're going to do a nasopharynx, a tear must come out from the same unilateral eye. If the tear doesn't come out, you didn't do a good job. Just that way. Okay. So just a thought on that, right? And then the second mantra was this, right? I think again, this is important because I do review charts. I do look at what all of you do. My only problem is that most of you do not do it for group. Asthma, first time wheezing is a big one. If I have a history of AFib, I have a history of everybody with fluorescent to wheeze at downstairs somehow. I don't know about things down here. Everybody wheezes. If there is no history of that, it's my first time wheezing, I would understand why you're getting it, right? If I have a bronchiolitis, why do I do an X-ray? Right? If I have no focal abnormalities to look at, my hypoxia, the definition of hypoxia to go home now with bronchiolitis is what? It's 90. If you're 90 and you have bronchiolitis and you are drinking well, you're going home with the gun. You're not staying, right? If you're severely hypoxic, I would understand you saying, I need to get an X-ray. But try your best to see if you can practice some of the things that we are talking about. Huh? I'm still not getting any questions. Okay. Now, the reason I'm bringing all of this is this is another bad thing I like. Everybody somehow at downstairs who gets admitted for pneumonia. Now, pneumonia is mild, moderate, and severe. So there is a society within AAP called Pediatric Emergency Medicine Society, and they came out with a very nice single-page flow diagram of how to manage pneumonia. And they call it mild, moderate, and severe. They use the word complicated only if you will have a terrible pleural effusion. And they guide you to say, if I have mild, go home. If I have moderate, put me into the floor. If I have severe, then put me into the ICU. And they tell you what antibiotic to use. And we were one of the 106 hospitals that participated in this study to come up with that flow diagram. And so it always bothers Tejani and upstairs people also when we use broad guns to treat a simple pneumonia because I'm not able to take PO when I'm having a problem with vomiting that I am admitted. Now I'm going to give you ceftriaxone or levofloxacin, right? I understand the guidelines for the adult 18 and older for admission is ceftriaxone and zithromax. Am I saying it correct? But that is not true for our pediatric population. So for pediatric population, so I get all these charts literally as a QI where everyone has received ceftriaxone in the ED admitted to the floor. They say, why are you giving them ceftriaxone, right? I have time, right? Okay. So if you meet these criteria, you are going to say, please take time to reflect. I am only going to give you ampicillin. The drug of choice for inpatient pneumonia is IV ampicillin. If you're going to send me home, you're going to send me home on PO and ampicillin. Simple to remember. Problem comes in, what if I have penicillin allergy? Two kinds, right? One is I have penicillin allergy. Then people do not talk about beta-lactams anymore. They talk about side chains, and they group into 1, 2, 3, and 4. And so if you are Capilex and amoxicillin in group 1, you can give me group 4, which is a totally different brand, which is a third generation antibiotic. So if you're penicillin allergy mild, you can give me a third generation cephalosporin. That would make sense, right? Or if I'm under-immunized, then you have a choice of giving me a third generation because I'm not immunized for suspect pneumonia yet. Or you can give me Augment. Actually, Unicin, both of them are under-immunized. But if you're allergic to penicillin, but you have anaphylaxis with penicillin, then the drug of choice would be clindamycin or levofloxacin. Right? I don't know if you prefer the same adults. Okay. Please help me in that if there's so that because now we skip to 21, so there's any discrepancy. And of course, we love the flu here and downstairs. I will do the antiviral that way. And add mycoplasma if you're over 5. We don't check on that mycoplasma less than 5. The guidelines are, even if it's positive, I'm still going to give you a marker. We don't put much weight on mycoplasma in that way. Worst is I have to go to the ICU. And then it's very different volume altogether, right? Oxygen saturation, unable to maintain 92, even on 50% FiO2, would automatically put me in the ICU, right? So just want you to understand which direction we go. And then I agree with either it is ceftriaxone or cefotaxime. If I have got multi-lobar pneumonias or cavitating lesion or something like that, then give staph, either Wenck or Clinda, right? And then if it's atypical, then you can azithromycin afterward. Be kind to remember that. I think antibiotic for me is a big thing now. I was going to talk about this, but it's already 9:10. Maybe for next time. It's a whole thing. The only thing I wanted to say is that because literally it is in the world, people spend, and this was just that came out in BMJ in February 2024, $42.7 billion on cold cough medicine. And the most takers are United States of America. They lost 199 children in Gambia because of the demand. They could not afford glycerol as a base to sweeten it. They added ethylene glycol, killing the kidneys of these 199 children because the demand for OTC, common cold medication, is so high. Right? And so we need to educate our parents. And then again, so just to shorten, everybody's using Zarbee's. Everybody knows what Zarbee's is. And every parent knows Zarbee's, if you're less than 5. It is a mixture of honey, ivy leaf extract, and elderberry roots. Then grind all 2 of them, mix it in that, and now they're adding a 4th component, so my child can go to sleep, is melatonin. Now I have more things in it. But I'm saying that it's unbelievable, right? So I was actually going to go compare each of them, run through the list, but it's okay, we'll do it. We'll take another 20 minutes down. So for next time, thank you so much for your time.